Whew, I just got done listening to part of the last session. I'm so sorry. Nothing worse than listening to yourself. Now we're on to pharmacology of glucose metabolism, focusing more on meds that are used in type 2 diabetes because they impact and prevent hyperglycemia more than they cause hypoglycemia. Our objectives essentially are the same, and I'm sorry in your version I had more in red from the previous lecture on this slide, but really we're looking at weight gain as an important concept again. Sebastian is here to remind us what's important. Again, two predictable effects of drugs that increase insulin, hypoglycemia, and weight gain. Not our story for today or right now. Our story for right now is lecture 18, the column on the right. So metformin's primary activity, like the thiazolidinediones, decrease hepatic glucose release. Metformin more than the thiazolidinediones, as well as improved insulin sensitivity. Also, we'll look more in depth at incretin mimetics, the GLP-1 analogs like liraglutide. Sorry, that's not in red in your version, but you do need to know liraglutide, since it's indicated both for weight loss and type 2 diabetes. And we'll also look in depth at our SGLT2 inhibitors. Go with the flozins, right? Other drugs in these two lectures, oh, look at there's Moosey. We already talked about these. I wanted to remind us that glucocorticosteroids can cause hyperglycemia and weight gain. So sorry for all the drugs in red on this slide. This is just to keep me honest. It's a full list. All the drugs in red here really, I mean, they're fair game for the exam. How about if I just say it that way? So when we look at this particular graphic, the left column is meds that can act through means other than increases in insulin. And then the bottom row is going to depict the two primary means of gaining control of fasting blood glucose. So really our metformin or biguanide as a drug that does not cause hypoglycemia. And then on the right are long-acting basal insulins like insulin glargine, insulin detamers, insulin degludec, and hopefully someday soon, insulin icodec. We've got to think about fasting blood glucose. If you have a patient who awakens with a blood glucose that's already elevated, say 150, and you put carbs on top of that, it only goes up from there. This is part of the reason why metformin is the initial drug for most patients with type 2 diabetes who fail with lifestyle measures alone, because metformin, since it's going to decrease hepatic gluconeogenesis, can really have a marked effect on that first thing in the morning, fasting blood glucose. So to help you out, here's some generic drug name families. I mean, there's a buttload of drugs here, right? So secretagogues generally are going to begin with GLI or GLI or GLY, except of course for the first generation, but glyburide is the drug to know for this exam, but also glimepiride and glipizide. Then we have the drugs that end in glyinide. Those are rapid on, rapid off, insulin on demand, meglitinide drugs like repaglinide. Our drugs going with the flow drugs, making the glucose flow drugs are gliflozins, canagliflozin, dapagliflozin, empagliflozin, etc. Thiazolidinediones are PPAR gamma agonists, end in glitazone, like pioglitazone. They work in the insulin zone to increase sensitivity to insulin. Our GLP-1 agonists are our tides, like exenatide, lixasenatide, liraglutide, dulaglutide, all of those. I want to point out that both the raglutide and semaglutide are indicated for weight loss, approved by the FDA. We have a newer drug, tirzepatide, which is a dual GLP-1 and GIP inhibitor indicated for type 2 diabetes as Mounjaro, and also or for weight loss as Zepbound. Then we have our dipeptidyl peptidase 4 inhibitors. They end in gliptin, which if you think about GLP-1 inhibitors, gliptin, like sitagliptin, Januvia, and then our alpha-glucosidase inhibitors, acarbose, and then of course miglatol can't fit any pattern, right? But acarbose really is the one to know because miglatol has a few other issues in addition to the flatulence and diarrhea that make people not take these drugs anyway. So here's some warm-up questions. Which class of anti-hyperglycemic is going to prevent hypoglycemic response to oral sucrose? So our alpha-glucosidase inhibitors like acarbose, remember, going to prevent absorption of dye and polysaccharides. Which classes of anti-diabetic drugs will delay response to oral carbs? Well, anything that delays gastric emptying is going to delay the response to, what you put in the gut. And so here really is our GLP-1 agonist, and then tirzepatide, our dual GLP-1 and GIP agonist. And the third question, what does hypoglycemia look like in a patient taking a beta blocker? Mostly just sweating. Again, we want to treat the patient, not the number. Diabetes, type 2 diabetes is complicated. Like we said before, it's kind of a vicious cycle. So we have inflammation. There's a lot of information out there saying that our SGLT2s, our gliflozins, our tides, our GLP-1 receptor agonists, our non-steroidal mineralocorticoid receptor agonists, finerenone, which we'll talk about in a moment, and our renin-angiotensin-aldosterone system inhibitors can really help suppress the inflammation. For hyperglycemia, most of our anti-hyperglycemic agents. For hemodynamic dysregulation, we're looking at ACEs and ARBs, our SGLT2 inhibitors, some of our GLP-1 receptor agonists, our non-steroidal mineralocorticoid receptor agonists can be used to hit that hemodynamic dysregulation. So a couple of points. Finerenone, is a non-steroidal mineralocorticoid aldosterone antagonist with less risk of hyperkalemia and much greater anti-inflammatory activity than spironolactone and eplerenone. So it's really only indicated in our diabetic population. It has equal affinity for the cardio and renal mineralocorticoid receptor, which means greater cardioprotection. Our SGLT2 inhibitors, our gliflozins, going with the flozins, are added even if glucose is under control when we have a urinary albumin to creatinine ratio that exceeds 300 milligrams per gram, and our estimated glomerular filtration rate is more than 24, because those drugs are relatively contraindicated in late stage renal failure. Oh no, biochemistry, sorry. When we get to metformin, hopefully this little brief review will help set us up for metformin. So it's a quick review of pyruvate dehydrogenase complex. So in the upper left, we're really looking at pyruvate dehydrogenase complex, PDC, being inhibited when pyruvate dehydrogenase kinase is activated. So PDK, the kinase, phosphorylates and inhibits the pyruvate decarboxylate complex. And remember that complex, what it does is it converts pyruvate to acetyl-CoA so that the acetyl-CoA can enter the St. George cycle, right? The tricyclic acid cycle, the Krebs cycle, whatever you want to call it, to generate essentially electrons for energy. Some of the things that are going to activate PDK to inhibit PDC include lots of acetyl-CoA. Okay, that makes sense. High levels of NADH, and I have a little symbol there saying that ethanol metabolism is one of the things that can increase that NADH to NAD ratio. If we move down to the lower left figure, we're looking at, on the left-hand side of the figure, things that activate the different isoenzymes of PDK1 to inhibit the pyruvate dehydrogenase complex. And then on the downward arrow to the right of the graphic, we're looking at things that activate the pyruvate decarboxylase phosphatase, PDP. And in this particular graphic, they emphasize that it's a calcium-dependent enzyme. I want to point out here that it's also a magnesium-dependent enzyme. And any of you who spend any time talking to me know that I'm a fanatic about magnesium supplementation. But when we have, most of us, the standard American diet, the SAD diet, very deficient in magnesium, unless you're like me and you eat 10 different plants a day. And the osmotic diuresis associated with diabetes, our thiazide diuretics, and our loop diuretics, all cause magnesium loss. So I think that most of us need a magnesium supplement, particularly those of us that have type 2 diabetes. Anyway, sorry about that. I went on my little rant. But some of the things that activate deactivation of pyruvate dehydrogenase complex are hypoxia-inducible factor 1 alpha. When is HIF1 alpha elevated? Well, how about sleep apnea, right? So I have a theory, and there's some articles out there saying that this is the link between sleep apnea and some of the cardiovascular and metabolic problems that occur subsequent to it. Also, insulin resistance, excesses of free fatty acids, glucocorticoid receptor, estrogen receptor, testosterone receptor agonism, and then our peroxisome proliferator activator receptor alpha agonists, these are our fibrates, can all deactivate PDC, which means that pyruvate doesn't enter the Krebs cycle, right? On the upper right-hand graphic is really representing the different steps in pyruvate dehydrogenase complex. But here, the nutrition kind of freak that I am, I wanted to point out that TPP, thiamine pyrophosphate, NADH, which is derived, of course, from nicotine, and FADH from riboflavin, our B complex vitamins are really involved in metabolism, glucose metabolism. So they're important. And also in the standard American or SAD diet, kind of lacking. Also, for quick review, glycolysis and gluconeogenesis. So the arrows that I have added, the purple and the glycolytic pathway, the green and the gluconeogenic pathway, are those that are unique and unidirectional in their respective pathway. So we see that glucose is trapped by glucokinase as it forms glucose 6-phosphate in the glycolytic pathway. Our next step is going to be phosphofructokinase, turning fructose monophosphate to fructose biphosphate. A couple steps go by, then we form phosphoenolpyruvate. Pyruvate kinase then is going to take phosphoenolpyruvate and form 2 pyruvate molecules, which can then enter the Krebs cycle, or if the Krebs cycle is backed up or not running, form lactate. So going up from the bottom on the gluconeogenic side, the 2 molecules of pyruvate catalyzed by pyruvate carboxylase form oxaloacetate, which when acted upon by phosphoenolpyruvate carboxykinase form phosphoenolpyruvate. A couple steps go by, we form fructose 1,6-biphosphate, which the fructose 1,6-biphosphatase forms into fructose 6-phosphate. A couple steps go by, and then we ultimately form glucose 6-phosphate and glucose. So I just wanted to point out that your biochem in MFM really wasn't for naught. There really is a reason behind it, and this is part of that reason. So let's look at some of the major actions of drugs for type 2 diabetes, and look at our little TJ there saying this will be on the test because medications that cause weight gain, really important to know. So what we have in this particular graphic on the left, we're looking at drugs essentially impact on weight gain. So the red or pink box are those that cause weight gain. Our yellowish box, weight neutral, and our green boxes are weight loss. So we have the different drugs here. Notice that insulin and secretagogues increase insulin in the body, so you can predict that they may cause weight loss. Our thiazolidinediones are peroxisome proliferator activator receptor gamma, PPAR gamma agonists, increase sensitivity to insulin in the body so much that there's also a risk of weight gain. We're going to talk about all of the words on this page class by class as we go. This is actually, again, from the American Diabetes Association Standards of Practice for Diabetes Care 2024, just kind of summarizing the different classes of drugs, giving you the dose. When you get out onto your clinical rotations, this particular set of guidelines is released every January, late December, early January. So it may help you because it also gives you dosing information. And I want to point out that cost is often a decisive factor. So we got to take into, the whole patient, right? If they can't afford a medication, they're not going to take it. It doesn't do them any good. For patients with obesity, we want to try to avoid those drugs that promote weight gain. We also have to think about comorbidities. So we're going to think about demonstrated benefits, but also risk of harms in light of those comorbidities. And just a reminder, some type 2 diabetic patients will require insulin. Our beta islet cells over time, get burnt out, if you will. And so sometimes it is just an inevitable progression. If you care, here's the American Diabetes Association guidelines. They change a bit every year. I don't want you to memorize the guidelines. My goal is so that you understand how the drugs work so that you can see why they're placed where they're placed in the guidelines. And here's the AACE similar guidelines. again, oh, sorry, I wanted to point out that the AACE has a, this particular set of guidelines is, oh, excuse me, for glycemic control, blah, 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 disease-centric, and, no, sorry, this is, yeah, comorbidity-centric, and the next slide is disease-centric. Sorry, I stuttered there a bit. Here's our first review question. Drugs and weight gain. 22-year-old female presents to the emergency department after a generalized tonic-clonic seizure. She admits that she discontinued the medication prescribed for her primary seizure disorder because it caused significant weight gain. Which medication in this list would most appropriately be trialed for maintenance of seizure control? Carbamazepine, divalproic sodium, ethosuximide, phenytoin, and topiramate. Well, sorry that I did put a little bit of knowledge of anti-epileptic drugs in there because ethosuximide is only for absent seizures, right? This is not what she had. So we can, well, ethosuximide may be associated with weight loss because it causes a lot of nausea. It is not indicated in this type of seizure. So now we have to pick which other one of these might be best for her. The answer is topiramate. So topiramate can actually cause weight loss. Therefore, that's probably where we want to go. Most of our anticonvulsant meds are associated with weight gain. Most of our antidepressants, our antihistamines, particularly those that penetrate the brain, atypical antipsychotics, those that block the 5-HT2C receptor. So remember, olanzapine with a big round first letter, clozapine with a big round first letter, quetiapine, sorry, that's the other one that has a big round first letter, high risk of weight gain. Cannabinoids increase appetite. Glucocorticosteroids increase weight gain. Woo! Also cause hyperglycemia. Glucocorticosteroids cause weight gain and hyperglycemia. Insulin secretagogues, thiazolidinediones like pioglitazone, progestins that we'll talk about next week in the repro section, and also statins may have an impact on increasing weight. So moving on, just a really quick summary of pharmacotherapy for obesity. Dr. DeFranco covers this. I just kind of wanted to give you a quick review of the pharmacology though. So phentermine is a sympathomimetic amine. It works kind of like amphetamine. It's going to increase release of catecholamines. So if you have a patient with hypertension, tachycardia, etc., Raynaud's disease, not your drug to go to. Then we have our lipase inhibitor, which is orlistat. Orlistat blocks the fat, right? So this is the one that's going to inhibit lipase to block fat absorption from the diet, causing oily yellow diarrhea, potential, particularly fat-soluble vitamin deficiency. We have the combination of our sympathomimetic phentermine with topiramate. We also have, sorry, I'm squinting at these because I'm having difficulty seeing them. Naltrexone, which is an opioid receptor antagonist with bupropion, a primarily dopamine reuptake inhibitor. And then here's the drugs that we're talking about today: liraglutide, semaglutide, our GLP-1 agonists, and tirzepatide, which is our GIP-GLP-1 combined agonist. Drugs for glycemic management. So we can lower our A1C 5 primary ways. So first, we can increase insulin in the body in a non-glucose dependent fashion, and we'll talk again what that means. Risk of weight gain, risk of hypoglycemia, insulin secretagogues, both our sulfonylurea class and our miglidinide class. We can decrease gluconeogenesis. That's a primary mechanism of action of metformin, a secondary mechanism of thiazolidinediones, the TZDs. We can make the glucose flow with our gliflozins, increasing urinary losses of glucose with our SGLT2 inhibitors like canagliflozin. We can increase sensitivity to insulin, thiazolidinediones, primary mechanism of action, a minor action of metformin, but also part of the action of our GLP-1 and our incretins, our GLP-1 agonists, GIP, dual 1 agonists, sometimes called incretins, and our dipeptidyl peptidase 4 inhibitors. We can delay or decrease carb absorption. Here's where fiber comes in. Also, our GLP-1 and our GIP-GLP-1 dual agonist, our DPP-4 inhibitors, can cause some delays in gastric emptying, which is going to delay the rise of blood glucose, and also our alpha glucosidase inhibitors like acarbose. That's how they work. So let's start by looking at the drugs that decrease hepatic glucose release and increase peripheral insulin sensitivity, metformin and pioglitazone. So this slide is looking at the regulation of PPAR gamma coactivator 1 alpha, deacetylation by the SIRT2 receptor activity. So in the upper left, we see fasting. When we have low nutrients, we get higher levels of cyclic AMP, which activates adenosine monophosphate activated kinase, AMPK, which in turn is going to activate nicotinamide phosphoribosyltransferase, NAMPT. It's also where metformin works. When we get high levels of NAD, we're going to increase activity of a histone deacetylase known as SIRT2. If you care, resveratrol in red wine, this is its target. When SIRT2 is activated, it is a histone deacetylase, so it's going to deacetylate the PGC1 alpha, making it active. And when PGC1 alpha is activated, we get increased mitochondrial biogenesis. So our PPAR gamma agonists like pioglitazone also is going to cause increase in mitochondrial biogenesis, increased mitochondrial autophagy. So basically what we're doing is we're making nice, new, sparkly, hardworking mitochondria while we are depleting our senescent older mitochondria that are leaking all these reactive oxygen species, theoretically, at least in my mind, is kind of how I think about it. So we get nice, fresh, new mitochondria, which improves efficiency of energy formation, as well as decreasing reactive oxygen species formation. So insulin and other growth factors are going to activate phosphorylation of the fork-head BOX1 transcription factor. So when we phosphorylate FOXO1, it's going to sequester it from the nucleus of the cell. And this leads to cell proliferation, cell survival, increased susceptibility to reactive oxygen species, as seen in panel A of this graphic. In panel B, when we have activation of adenosine monophosphate kinase, this is, well, it's a kinase, it actually is bidirectional. It can also act as a dephosphorylator of fork-head BOXO1. This is going to increase expression of genes, through activation of that SIRT2 histone deacetylase that are going to promote cell cycle arrest, apoptosis, and detoxification of reactive oxygen species. Metformin actually is thought to have some anti-cancer effects, and also not so surprising that hyperinsulinemia is associated with inflammation and increased risk of cancer, right? So metformin is a biguanide. In the graphic here on the right-hand side, I have galagine, which was actually an herbal, the French lilac, Galega officinalis. One of the traditional uses, has been kind of for the diabetic presentation. So that's kind of interesting since, I'm a plant freak. So basically metformin and galagine are charged at physiological pH. So they're uptaken by the organic cation transport 1 to get inside the mitochondria. Once there, they're probably going to disrupt complex 1 to reduce ATP synthesis, which increases AMP. And when we have high levels of AMP, we get activation of the adenosine monophosphate activated kinase. One of the most important part of metformin's effects is its ability to inhibit gluconeogenesis. Again, this is going to have a huge impact on fasting blood glucose. Metformin is going to increase formation of pyruvate, and this is one of the reasons that it poses a risk of lactic acidosis. So metformin is pleiotropic, meaning it has lots and lots of effects. In this particular graphic, the red circles are metformin's actions, the green circles are glucagon's actions. Metabolically, we get increased pyruvate formation from metformin, but also increased beta oxidation of fatty acids. Don't worry about the details. I just wanted to show you that it's biochemistry again. It's essentially that gluconeogenic and glycolytic pathway that we looked at earlier. The net result of metformin's actions decrease gluconeogenesis. We get controlled fasting blood glucose comes under control. We also get some increased peripheral insulin sensitivity and actually increase secretion of glucagon-like peptide 1. Additionally, we're going to see reductions in MAP kinase. Again, metformin may have an additional protective effect against neoplasia. AMP kinase and HMG-CoA reductase. In some of the older literature, you'll see where they claim that metformin has a beneficial effect on lipids from the UK PDS trial. We found that it really maybe not. So it's not considered to be cardioprotective. Don't memorize this, okay? But this is just all the pleiotropic effects of metformin and adenosine monophosphate kinase activation. Effects of metformin. Oh, look, there's our little Daisy Wow bot. We can get, and especially in an overdose situation, lactic acidosis with low risk of hypoglycemia. And again, it's mostly used to help normalize that fasting blood glucose, because if you wake up with a high blood sugar, it only goes up once you start putting carbs in the mouth. The biggest side effect of metformin in the short term is GI, upset, diarrhea, flatulence. So we normally tell patients to take metformin at least at initiation with food. In the hospital, it's been my experience sometimes, the nurses think that metformin is going to cause hypoglycemia and they'll want to hold it if the patient doesn't get their meal. This isn't the case. It really just is because of the GI nauseant effects. One of the things from my perspective as somebody who's a nutrition freak also is that metformin is known to cause B12 deficiency. So want to supplement B12 in patients who are on metformin. What does B12 deficiency look like? Well, we'll probably have a macrocytic anemia. It can progress to peripheral neuropathy. And remember, B12 is needed for entry of methylmalonic acid into the Krebs cycle. So elevated methylmalonyl levels are indicative of B12 deficiency. Another important thing is that metformin may also contribute to magnesium deficiency. I have a question mark there because we're not sure. So probably not a bad idea for all people to have magnesium in their diet, especially for metformin. Metformin is considered to be weight neutral. So here's some detail about metformin and lactic acidosis. We have basically 3 levels. MILA, high levels of metformin, is definitely metformin-induced lactic acidosis is what MILA stands for. So in overdose, this is actually the I've seen lactic acidosis from metformin 3 times. 2 of them were intentional overdoses, and 1 was due to radiocontrast dye shutting down the kidneys, loss of renal function. So we see that acute ingestion, chronic accumulation with an EGFR less than 30 is what causes that lactate due to metformin. On the other end of the spectrum, we can also have EULA, which is lactate due to other illnesses, acute illnesses. So bottom line, we still need to think about lactic acid with metformin. And we also said that metformin is going to increase formation of pyruvate. In the graphic at the left, you'll notice that ethanol, and we mentioned this before, increases NADH production, which decreases activity of the pyruvate dehydrogenase complex, meaning that ethanol acutely is going to increase shifting of that pyruvate to lactate. So in the middle here, the MALA, ethanol, acute ingestion of ethanol is a risk of this dual cause of lactic acidosis. What happens with metformin, remember, it's blocking the entry of pyruvate into the Krebs cycle. The pyruvate therefore backs up, and pyruvate's got to go somewhere. When it backs up, it turns into lactate. So this rare risk of lactic acidosis with metformin is increased when there's excessive metformin serum concentration. So that's overdose, renal impairment, including that radioiodinated contrast media that shuts down kidney function acutely. And then when we have chronic decreased renal perfusion, like heart failure, we're not perfusing the kidney. We also may have increased lactate production, so our hypoxic states, again, heart failure. High NADH ratio, for example, from acute ethanol consumption. We can also have decreased lactate clearance. So lactate is primarily cleared in the liver. So anything that decreases liver perfusion, like heart failure, or anything that, decreases liver efficiency, like hepatic disease. Here's where chronic ethanol consumption comes in, but also underlying acidosis or carbonic anhydrase inhibitors, including the drug topiramate. Remember, one of its side effects, if you will, is inhibition of carbonic anhydrase, but also diabetic ketoacidosis. I want to point out that stable heart failure is not a contraindication for continuation of metformin unless the heart failure is unstable or their eGFR is less than 30 mils per minute. Moving on to our thiazolidinediones, also known as TZDs, also known as glitazones, also known as PPAR gamma agonists. On the left is a very complicated schematic because their activities as transcription factors, pretty complicated. So insulin signal transduction and the PPAR pathways. So here we're looking at insulin binding to its receptor, activating the insulin response element that's going to either activate the metabolic pathway. We can get activation of the transcriptional pathway, which includes suppression of the forkhead box 01, right? And then we can also activate the mitogenic pathway, the MAP kinase pathway, leading to the mitogenic effects. So the primary effect of thiazolidinediones is to increase peripheral sensitivity to insulin. We get adipogenesis, lipogenesis or weight gain, and we also see increased expression of ENaC in the collecting ducts of the renal tubules, which can lead to sodium and water retention, which can make heart failure worse. We also probably are going to see a reduction in the risk of stroke and MI with our PPARs. And we also probably, there's a lot of work being done right now to look at the PPAR gammas to treat non-alcoholic fatty liver disease. So PPAR gamma agonists, the thiazolidinediones, pioglitazone actose, for your information, rosiglitazone avendia, which is not used as widely because there's some association with heart failure, are primary benefits to increase peripheral insulin sensitivity. Though remember, they do have a impact as anti-inflammatory agents. They also reduce fasting blood glucose by inhibiting gluconeogenesis. They are, however, implicated in increased risk of fractures, anemia, macular edema, weight gain, possibly diabetes. Our thiazolidinediones are contraindicated in patients with heart failure because they increase sodium and water retention, and that makes heart failure worse. It's actually additive with insulin because, again, insulin also increases ENaC expression. Troglitazone was the first thiazolidinedione on the market. It was withdrawn due to hepatotoxicity. Moving on to drugs that are reducing carb absorption. So our first one, alpha-glucosidase inhibitors, acarbose and miglatol. Acarbose is on your list of drugs to know. They're going to block the endoenzymes that digest more complex carbs. Adverse effects, mostly GI, because if those carbs don't get absorbed, they get fermented in the gut, and that leads to osmotic diarrhea, and lots of flatulence. So don't want to get in the elevator with these patients. Sorry, bad joke. Contraindicated in patients with GI disease because of the GI issues. The big thing we want to think about in a patient on acarbose is that if they're on another drug like a secretagogue glyburide or insulin that can cause hypoglycemia, if they're also on acarbose and they drink orange juice, they take some sucrose from table sugar, they have some lifesavers, they're not going to be able to absorb those carbs because you have the alpha-glucosidases blocked. We're soon going to be in the GI section. So here's our GI connection. The molar ratio of sodium to glucose for absorption is 2:1 for the SGLT1 in the gut. This is really important when we talk about oral rehydration and diarrhea. Without salt, the glucose actually acts like an osmotic laxative. Anyway, so we'll get there. Moving on to the incretin mimetics. These are our GLP-1 agonists like exenatide, liraglutide, semaglutide. Our GLP-1 GIP agonist tirzepatide, which is Mounjaro for type 2 diabetes, Zepbound for weight loss. And our dipeptidyl peptidase 4 inhibitors, the gliptins like sitagliptin, Januvia. So our incretins are GIP and GLP-1. On the upper right-hand corner diagram, we're really looking at chyme nutrients entering the gut. When the chyme enters the gut, our K-type cells are going to release GIP, and our L-type cells are going to release GLP-1. This causes, if you remember from our discussion of the sulfonylurea slide, we pointed out that G protein coupled receptor that was activated by our incretins that increases the sensitivity of that outward flowing potassium channel to ATP. So kind of this feed forward, preparing the body, preparing the pancreas, saying, oh my gosh, there's some nutrients in the gut. So when we give intravenous glucose that bypasses the gut, we often see a more hyperglycemic response because we don't get that increased sensitization of the beta islet cell from our incretin mimetics. I'm trying to help tie that all together for you. So this is why IV glucose can cause hyperglycemia compared to an equivalent oral glucose load. These drugs are incretins. Oh, I also want to point out, I'm sorry, before we get there, in the little red box in that diagram, it says dipeptidyl peptidase 4, DPP4. Our endogenous GIP and GLP-1 are degraded by this enzyme, dipeptidyl peptidase 4. So our GLP and GIP-1 agonists and our dipeptidyl peptidase 4 inhibitors are going to slow gastric emptying, which delays carb absorption. It's going to blunt the height, the Cmax of that postprandial glucose. They're going to increase insulin sensitivity and improve satiety. On the left, we're really looking at the impact of GIP on the far left-hand side of this diagram and GLP-1 on the right-hand side of this diagram. I'm just kind of explaining the effects. Notice a benefit of glucose insulinotropic peptide, GIP, is going to be increased bone formation. Our glucagon-like peptide 1, we have cardioprotective effects. So now think about the diabetic patient who's got, probably an older patient, probably has some risks for maybe bone loss. That might be an indication to use tirzepatide, the dual agonist, over a monoagonist. But also anything with GLP-1 activity, strong GLP-1 activity, probably going to be cardioprotective. Oh, I forgot that I put this slide here, glucose-dependent insulin secretion. So this is looking at the beta islet cell, the pancreas again. We have a low risk of hypoglycemia from our GLP-1 and dual agonists because they work by increasing sensitivity of the beta islet cell to release insulin in the presence of glucose. So this is a glucose-dependent insulin secretion. So our agents, again, are GLP-1 analogs. Some of them are approved for weight loss. I have weight loss in parentheses because generally they probably are associated with weight loss. Exenatide, albiglutide, dulaglutide, liraglutide, in red underlined Victoza for diabetes, Saxenda for weight loss, lixisenatide, semaglutide, in the news all the time now because it's short, it's in back supply. Insurance companies don't want to pay for it because it's expensive, but it's under injectable form for diabetes, Ozempic, oral form for diabetes, Rybelsus, and injectable form for weight loss, Wegovy. Our dipeptidyl peptidase 4 inhibitors, remember, these are our gliptins. They're going to block degradation of endogenous incretins, both GIP and GLP-1. The problem in type 2 diabetes partially is impaired secretion of our incretins. So these DPP4 inhibitors don't really give us a lot of bang for our buck, things like sitagliptin, Januvia. And again, tirzepatide is our dual agonist. So our effects of GLP-1 receptor agonism, delayed gastric emptying. So in this graphic, on our y-axis, we have our plasma glucose. On our x-axis, we have time after a meal. And our pink line is our placebo. The blue line with the circles instead of the squares is with a, I think it was with exenatide, if I'm not mistaken, in this particular study. So really what we're seeing is that delay of gastric emptying is going to delay carb absorption. We get a blunting of our postprandial glucose peak. So if you think about the HbA1c being a measurement of high blood glucose levels, because that's when those glycosylation end products bind to the hemoglobin, we really get a great impact on postprandial impact on A1C from this class of drugs. The problem is that we can get a delayed response to oral glucose in cases of hypoglycemia, so that's something to think about. Might want to keep glucagon on hand. Also, these drugs are known to cause gastroparesis, and they're contraindicated in somebody who already has gastroparesis. If you care, these incretin mimetics were originally discovered through examination of Gila monster saliva. Gila monsters only eat once every couple of months. So, I think that's kind of cool. These drugs cause satiety beyond their capacity for delaying gastric emptying. So they are indicated, some of them, in weight loss. They enhance glucose-dependent insulin release, as we already talked about. They increase sensitivity to insulin, reduce hepatic glucose output, in other words, inhibit pancreatic alpha islet secretion of glucagon, not so much tirzepatide, but the pure GLP-1 receptor agonists. They increase release of amylase and lipase. So this is thought to contribute to the risk of pancreatitis, so they are contraindicated in patients with pancreatitis. And again, we have demonstrated cardio benefits. Recently, they've been in the news because there was supposedly associated suicidality and alopecia risk. The FDA has warned that they did not, or has, not warned, has decided that there is not, at least on preliminary investigation, a causal link between suicidality and our GLP-1 receptor agonists, but it requires further study. Okay, moving on. Dipeptidopeptidase 4 are gliptins, are dipeptidopeptidase 4 inhibitors, and they're going to inhibit the deactivation of GLP-1, and quite a few other things. In the periphery, DPP-4 inhibitors block the dipeptidopeptidase 4 regulated enzymatic degradation of our incretins. This is going to increase insulin secretion from beta islet cells in a glucose-dependent fashion, also reduce glucagon secretion, reduce apoptosis of beta cells, promote beta cell proliferation, increase peripheral glucose uptake, ultimately going to cause a reduction in postprandial blood glucose levels. But other things are also degraded by dipeptidopeptidase 4. So we have things like bradykinin and substance P that are substrates of dipeptidopeptidase 4, neuropeptide Y. This is thought to lead to the reported adverse effect of pain and arthralgias from DPP-4 inhibitors. We also see a decreased inflammatory response because some of the cytokines that suppress monocyte reactivity are degraded by DPP-4. So I think I looked at a ComBank practice question, and it was sitagliptin's increased risk of respiratory infection. That's the most common adverse effect with this class of drugs. So those are some of the side effects to think about with our DPP-4 inhibitors. Difference between incretins versus DPP-4. So our incretin agonists, like the raglutide, we're giving a super physiologic dose, so we get super physiologic effects, including significant satiety leading to weight loss. A lot of patients complain actually of nausea after eating with these. So smaller meals, lower processed carb content of meals. Again, these drugs are contraindicated in pancreatitis because of that risk for increased amylase and lipase. But also in the rat model, these drugs are contraindicated in multiple endocrine neoplasia 2 syndrome because of a risk of medullary thyroid cancer in a rat model. Our DPP-4 inhibitors decrease the deactivation of our endogenous incretins, but other things also. So we have increased risk of infection and pain, probably an increased risk of angioedema with ACE inhibitors due to blocking a second pathway for bradykinin breakdown. Contraindicated in gastroparesis, contraindicated in pancreatitis in men too, just like our GLP-1s. And we see a much smaller impact on our A1C. So far, no ASCVD benefit seen from our gliptins. Tirzepatide, Mounjaro, adverse effects as with GLP-1. So it just also is an agonist of GIP and GLP-1. Lots of information. This is just showing some of the data from the SURPASS trial, looking at weight loss, evidence-based medicine with tirzepatide and type 2 diabetes. So the first set of graphics is no background oral anti-hyperglycemic meds. We saw weight loss even with placebo. When compared to semaglutide, we saw a better weight loss from tirzepatide. When combined with insulin degludec, notice that there was weight gain with the insulin as our placebo, but weight loss from our tirzepatide, similar with insulin glargine. And then in the third the Surpass 5 trial, which was looking at tirzepatide versus placebo, there we saw a weight gain with placebo. Anyway, that's evidence-based medicine. Looking at our clinical trials with GLP-1, just kind of FYI, since 2008, the FDA has required that diabetes drugs demonstrate no cardiovascular harm because we actually found cardiovascular harm from our sulfonylureas. So they have to do these non-inferiority cardiovascular outcome trials. So far, liraglutide and dulaglutide have had superiority testing. The LEADER trial enabled an FDA-approved indication for cardioprotection with liraglutide. In addition, liraglutide, dulaglutide, semaglutide all have a beneficial effect on renal function. DPP-4 inhibitors, looking at non-inferiority trials, FYI. I just wanted to point out that saxagliptin, if you go to the last row, we actually have an increased risk of heart failure hospitalization, at least statistically. But remember, an alpha of 0.05, 1 in 20 significant findings is just due to random chance. Moving on. Let's go with the flow. Our gliflozins, SGLT2 inhibitors like canagliflozin, dapagliflozin, etc. They're going to inhibit glucose reabsorption in the S1 segment of the proximal tubule. This has a benefit in heart failure and a benefit in early kidney disease. But on the downside, we can see bone loss and fracture risk, increased risk of Fournier's gangrene in the genital area, which is necrotizing fasciitis of the perineum, but also increased genitourinary infections, hypovolemia and hypotension. Juice wants to remind you, that's Juicy there. I got to meet him the other day. It was amazing. But Juice wants to remind your patients that fluid intake is important on SGLT2s so that the patient does not become hypovolemic and hypotensive. Canagliflozin possibly increased risk of amputation. Sometimes we see euglycemic ketoacidosis. It's a rare effect, but it does happen. Also, risk of pancreatitis. The big advantage is the weight loss, the benefit in cardiovascular disease and chronic kidney disease. If you care, here are our significant trials involving our SGLT2 inhibitors. Miscellaneous FYI, bromocriptine cycloset is thought to reset the central circadian control of satiety. Colesevelam Welchol is a bile acid sequestrant postulated to improve insulin sensitivity through reductions in hepatic bile acids. It's going to activate that fibroblast FGF1 receptor, which is a satiety receptor. Pramlintide Simulin is an amylin analog used with insulin rarely in type 1 and type 2 diabetes to help prevent wide swings in blood glucose. That's done. Here's some herbs that are possibly effective and likely safe. So largely fiber, magnesium, and soy. Beyond here, I have some summary slides for you, drugs and weight, skip meal, skip med, some combination agents, and then some practice questions. Thank you, and I hope you are enjoying your snow day.